Okay, moms, let's talk to all of you who have found out your baby is not head down at the end of pregnancy. Hey, I'm Dr. Shaunna Mason. I'm a board-certified OBGYN practicing in Houston, Texas, helping moms know more about their body as they get ready for labor and have a smoother recovery postpartum. So breech babies who are not head down, or what we call malpresentation, means any baby that isn't in the head down position. So babies can be sideways, they can be at an angle, which is oblique, or they can be bottom first. So let me show you this a little bit more in regards to how your pelvis is. So if you're a mom and here's your pelvis, we need your baby to be coming head first. We don't really care until you're in labor whether the baby is facing your pubic bone or facing the back, but we do need the baby to be head down. So if you go in for an ultrasound in the third trimester and you find out that your baby is not in the head down position, what that means is your baby could be sideways or transverse, either with the legs and arms hanging down, or sideways with the legs and arms facing up towards your lungs and diaphragm. Your baby could be at an oblique presentation, either at an angle, favorably with the head almost down, or bottom almost down, and that is considered oblique. That means no part of the baby is actually engaged. The bottom isn't in the pelvis or the head, but they are still on an angle or a sideways tilt. There's also breech presentation, and there's a couple of variations of this babies find themselves in. One is breech presentation. Both legs are up and our baby is sitting down into the pelvis. This is called a complete breech. There is also where our baby is sitting with their legs crisscrossed and sunk down in the pelvis, and that is known as frank breech presentation. There's also single footling breech, which is one foot has dropped way down into close to the cervix or the vagina, and then double footling breech, which is where both feet are sitting down and the baby's on top of it. So these are all of the different positions that babies can find themselves in at the end of pregnancy that then moms are having to navigate. How often does this happen? How worried do you need to be if you're watching this before you even get to the third trimester? So great news, moms, 93 to 96% of babies will get into the correct or head down position by full term. And full term, as a reminder, is 37 weeks pregnant. So most of us are not going to have to deal with our babies being in the wrong position, but about 3 to 7% of you moms are going to have to navigate what comes next if you find out that your baby is not in the right position. So how does your doctor know that the baby's in the wrong position? Well, sometimes we can feel your belly and we can tell that nothing is low. We can feel the hard head and we can feel usually a hard tush, although it's not as hard as the head. And then we can feel in your upper abdomen and try to determine by something called the Leopold's maneuver, which is basically where we just push on your belly in different places to feel where the baby is, right? But usually at the end of your pregnancy or later in your third trimester, your doctor will schedule a last ultrasound. And this does a couple of things. It tells us the baby's position, it gives us an estimate on the baby's size, and it lets us know how much fluid is still around the baby and how healthy the placenta is looking. So usually between 32 and 36 weeks, your doctor will have an end of pregnancy ultrasound scheduled. So if yours falls closer to 32 weeks and we find out that your baby is not in the head down position, then your doctor will usually schedule a follow-up in another month. Basically, we give this baby a whole nother month to get themselves right before we have to start strategizing what comes next. So only 3 to 7% of us will have to deal with our babies being in the wrong position, and we usually get an idea that this is what's going on between 32 and 36 weeks. So what if you find out your baby is breech before one of these 32 or 36 weeks ultrasounds? Should you even be worried? The answer is no. Do not worry if your baby is not head down at one of your earlier ultrasounds, especially if your baby's breech at your anatomy scan. Think about it being in the deep end of the swimming pool, one of those deep end swimming pools that has the high dive and all the fun stuff that we loved as kids. Your baby still has the deep end to do somersaults all day long. We could look 1 hour and your baby's breech. We could look the next hour and your baby's head down. They have a lot of movement inside, and when they are little and the space is very roomy and the fluid is very abundant, They will flip all around all the time. But as we get closer to our due date or full term at 37 weeks, a few things start to happen. Our baby gets bigger, so they're taking up more of the space. And the fluid tends to drop a little bit, so they are more in the shallow end. And while you can still do a front flip in the shallow end, there's a lot more obstacles you have to encounter, right? Sometimes they're too big to fit. Sometimes the uterus is a little tighter because contractions are starting to happen as our body practices and prepares for labor. And sometimes the fluid has dropped down. So now our baby's having to navigate turning in the shallow end instead of the deep end of the swimming pool where they have tons of space. So if you're one of those moms who has a breech baby at some of your earlier ultrasounds, you just take that worry and put it in a bucket of, I will not worry about this until the end of my pregnancy because my baby still has tons of time to turn on their own. At 32 weeks, I think it's reasonable to start thinking about the what ifs, right? Okay, so this baby has another month to turn. Statistically speaking, odds are in our favor that this baby's gonna find their way around, but what is our plan if the baby doesn't? At the 36-week visit, if we confirm that the baby is not head down, we start to talk about what our options are. So when our babies are breached, we have a couple of things that we can do to try to navigate this frustrating situation. One is we can schedule you for a procedure called an external cephalic version, or an ECV if you look it up. And this is a procedure often done in a hospital with the monitoring of the baby, an operating room available, and anesthesia to help keep you comfortable, where your obstetrician and usually a co-colleague, where we actually maneuver the baby so that we can encourage them to either do a back flip into the vertex or head down position or a front flip into the vertex position. And the way we do this is we lift whatever part is down. So we lift the baby up out of the pelvis through your abdominal wall, right? So we're putting pressure on your abdomen at different pressure points to disengage or lift up whatever is sitting in the pelvis. So our goal is to bring that bottom above your pubic bone and out of your pelvis into your abdomen. And then we apply counter pressure on the baby's head. So pressure at different points to encourage the baby to turn on their own is our hope. And then if we can get that baby to settle down, we'll often put an abdominal binder on to help the baby limit the laxicity that we might have just created in the uterus by getting them to turn, so that they will sink down into the pelvis and then become engaged, where it becomes much harder for them to turn. Once they drop down into the pelvis, whatever part is down there usually stays, which is why we want to do the version, if we can, closer to a time where your baby hasn't become fully engaged. We don't want that bottom to fall really deep either. So we want to be able to lift that bottom up and get that baby to either do a forward flip or a backward flip into the head down position, but then we want to encourage that head down position to engage so that the baby doesn't have the opportunity to flip back. So things you can do to help your baby engage is a lot of standing and walking and sitting on your birthing ball so that your pelvis opens up and there's plenty of space for that baby to drop down and kind of sink in, right? And so that is what an external cephalic version is. It is physically putting pressure on your abdomen to create an opportunity that encourages your baby to do either a forward or backward roll inside the uterus. So we often do this with anesthesia because it can be a very painful, uncomfortable procedure for moms. So many doctors will encourage you to get an epidural or consider IV pain medicine. We often use medications to help relax the uterus. When we start pushing on your abdomen and your baby starts turning in response to that, the uterus will spasm or have little contraction. And we need that to not happen. We need that muscle to be very flexible and relaxed. So we'll use a medication that creates a smooth muscle relaxant inside the uterus. And that medicine can make you feel a little racy, make your heart kind of race. It's very similar to things like albuterol that we use when we have asthma to relax the tightness in our lungs. So we can use similar medications with supervision and monitoring in the hospital to relax the uterus and encourage more flexibility or elasticity for the baby to actually turn inside. We often monitor the baby because unfortunately, when we encourage babies to turn, it can be stressful for them. We can also unfortunately put pressure on the placenta, or if the uterus is spasming or contracting around the turn, then that can cause some decreased blood flow through the placenta, and not all babies tolerate that very well. So the risk of the procedure is that we could cause stress in the baby that may not resolve and may lead to an emergency C-section. I do think it's really important to understand that the procedure has different variables of success unique to each mom, and it does come with some risk. Things that make you a really good candidate to consider an external version is if you've had a baby before, right? If we know that your baby can get around into the head down position, if we know you've had a vaginal delivery before, we know your body can get you all the way to 10 centimeters, you can push a baby out. So these things can improve our success. Also, having a posterior placenta improves success. So just think about it's one less layer that we're not having to push through or manipulate. A posterior or a placenta that is towards your back instead of your belly button helps us a lot. And then having a good amount of amniotic fluid. So again, thinking about helping your baby turn in the deep end of the swimming pool versus the shallow end improves those success chances. It's often also the reason why we wait until about 37 weeks before we consider a version. Now, every doctor has a different theory and philosophy about this, but that's generally what's recommended because we have a full-term baby. We're not as big as we're ultimately going to be by waiting until 39 weeks. If we found ourselves ending up in a stressful emergency C-section, your baby is still very ready to be born. So that is what an external cephalic version is, and what your doctor may talk to you about, and what you may consider with your family and your healthcare team if it's right for you, if your baby is not in the head down position. What can you do at home? So things like yoga positions where we can elongate our core. So doing a lot of downward dog really kind of stretches things out and can pull that baby up out of your pelvis and give them more space in the abdomen where they may want to turn again. Or doing child's pose, kind of alternating between these things. It just stretches and opens our core in different ways that regular movement or sleeping or stretching may not actually do. So doing these exercises routinely can be really helpful. Being in tabletop position where you kind of do circles with your hips and pelvis. Again, these things kind of rock the baby around and open up the pelvis and stretch out the core. And we believe that these things can encourage a baby to go ahead with that movement and turn around. There are some theories out there that you can play music at different spots on your abdomen, and that will encourage the baby to move towards the vibration and sound. Or the same with hot or cold packs, that you can kind of place them at different spots on your abdomen, and the baby will navigate away from the cold or towards the warmth, and that may encourage your baby to flip around. There's also patients who feel very comfortable using prenatal massage or a chiropractor or even acupuncture to just manipulate your body to then give the space the baby needs to encourage them to flip around. And I think if you are working with a provider that you feel very comfortable with and they have a lot of experience, then these things can be very safe. Remember, this isn't manipulation to the baby like we do with a formal external cephalic version. These are manipulations of your body that allow the creation of more space to encourage the baby to flip around. And then the last option is a scheduled C-section. So whenever we open up your belly and we take this baby out, we don't need them to be head down. We can deliver them in any of the position, feet first, back, sideways, bottom down. It doesn't really matter because we can open up the space in the uterus that we need to safely navigate the baby out. So a scheduled C-section is what some patients choose to do if their baby doesn't turn, or they decide that an external cephalic version is beyond the risk that they're willing to consider, and if the baby doesn't spontaneously vert by about 39 weeks. So 39 weeks is really our favorite time to deliver babies if we can. We have gotten past even the risks of early term babies, so some respiratory transition, some jaundice issues, or maintaining our body temperature. Sometimes even our 37 to 39 week babies can struggle with that. But 39 weeks, we've made it past those risks, and we have often able to schedule your C-section before your body has started laboring. We really don't want you laboring a bottom first baby because it can be dangerous if the baby is coming through the pelvis breech presentation. Now, there are still some obstetricians who will deliver a baby breech, but that's very unique. The problem with the baby coming out breech is that this is not our biggest part of our baby, right? We still have our whole head and shoulders that we have to get out. So we found that babies who tried to come breech had a very high risk of getting stuck in the pelvis because these are our biggest parts. And so some of the baby would come out, but not all of the baby. And that could put the baby at severe risk of having injury or having oxygen deprivation or having maternal vaginal trauma for instruments we were having to use to try to get the baby unstuck in this sort of stressful moment. So this is why in our field, after many years of research and experience, that we sort of moved away from delivering babies breech vaginally, except for those very few unique situations. So I think understanding that babies do end up breech, it's not the majority, and there are some things we can do to try to help them get around, whether you're doing that as a scheduled procedure with your doctor or you're trying these techniques at home, I think can help moms feel like they're at least doing something. I think it's really important that you know it is not your fault if your baby doesn't get around. You know, babies are really smart and we don't always have the ability to understand why they're choosing this pathway out. Sometimes they're tangled in their umbilical cord and they just can't get around. They've tried, they want to do that somersault, but when they do, that cord gets really tight and it starts limiting some of their blood flow, so they stop. Sometimes the shape of the uterus inside, women can be born with uterine anomalies that we may not know about. We can't see them on ultrasound, either before you get pregnant or as the baby's growing. So sometimes there's little divots or heart shapes inside the uterus or certain scars that we are actually born with called septums that can limit the baby's space. And so they try to turn, but there's no space there, so they stop. There's also sometimes just the way the placenta is formed or how it's taking up or occupying space in the uterus that your baby's kind of gotten stuck or wedged around that, and they just can't figure out how to get past that little block. Or the fluid around the baby has just gotten too shallow that they can no longer do the somersault that we need them to do, whether we help them or they try on their own to go ahead and get around. And then lots of times we just don't know. I mean, babies just choose the path they want. And remember, the great majority choose head down. They do know which way is the easiest to come out, but sometimes they just can't do it for reasons that we don't get to know. And our job is to help you stay as informed as we can, help you know the risk and benefits and what your options are, and try to come up with the best plan for you and your baby and your doctor. So I really hope this video has helped you moms who may be worried about having a breech baby, kind of understanding how common it is, how we know, and what you can do at home and what your team may be able to do to help get your baby around. If you had an experience with a breech baby or a baby that was turned funny and you were unsure about how to get through it, please drop the comments below. I'm sure they'll help someone else. And check back next week and we'll have another video to keep helping all you moms out there navigate the end of your pregnancy